of opioid. Heath Ledger died of an overdose 3 years ago, I think, and then Tiger Woods, of course, was arrested for a DUI just a little over a year ago and went into a drug treatment program to overcome his drug issue. So just an outline for today. These are the types of things that I'd like to cover with you over the course of the next 50 minutes or so. First, just the definition of terms, what do we mean by the various terms associated with the opioid crisis. Then a look at the epidemiology of the epidemic itself, including some national data as well as how the crisis varies across regions and across states. And then a little history about how we managed to get into the problem that we're currently facing. And then finally, a few slides on how to go about addressing the epidemic from a public health approach, including a look at prevention and treatment, and then naloxone, which some of you may have heard about, but I'll explain more about naloxone when we get to that part of the presentation. And then, unfortunately, a look at the reality of the world that we live in and how difficult it's going to be to address this problem. So first, terminology. The word opiate refers to natural substances that are derived from opium, for example, morphine and codeine. The word opioids do not occur naturally, but bind to the same receptors that opiates bind to. And there can be semi-synthetic opioids, which are hybrids of natural opiates, and that includes heroin, as well as oxycodone and hydrocodone, which are common prescription medications. And then fully synthetic opioids, which are completely chemically manufactured, and that includes fentanyl, methadone, carfentanil, which is an interesting drug that's 10,000 times more potent than morphine. And the reality is that opiates have been around and have been used to control pain for thousands of years, and actually date back to as far as 3400 BC. And we'll look at that in a little more detail when we look at the history in just a couple of minutes. So this is a map of the U.S., and this is the prescribing rates by county across the country. And one of the things that you'll notice, let's see, I think I have a pointer here. I don't see it up there. Maybe you can see this arrow. One of the things that you'll notice in terms of prescribing rates is the highest rates are the darkest colored counties. And the lowest rates are the lighter colored counties. And these darker colored counties are really concentrated in what's essentially the Appalachian region of the U.S., as well as along the west coast, and then sort of moving into southern Nevada and northwestern Arizona. But the striking thing about this to me is what those dark colors mean. So essentially, it's greater than 112 prescriptions per 100 persons. So that essentially means that within these counties, there is more than one prescription per person per year in those counties, which is really just baffling to me. So moving on, here's a headline from a couple of years ago: Americans consume the vast majority of the world's opiates. And so the reality is that the U.S. comprises of less than 5% of the world's population, but consumes 80% of the global opioid supply. And by the way, 2/3 of the world's illegal drugs as well. And if you look at the chart to the just to the right of that headline, you'll see the top 5 opioid countries over the past several years, and the U.S. is by far above all of the others, followed by Canada and Germany, with Denmark and Austria having a consumption rate of about half of the U.S. rate. And here's a headline from just December of this past year: opioid abuse in the U.S. is so bad that it's starting to lower our life expectancy. but for whatever reason, the epidemic doesn't seem to hit other countries in the same way that it's hit the U.S. So in addition to the prescription opioid crisis, there has been a concurrent rise in heroin use, and that is primarily coming out of Mexico, the Jalisco region of Mexico to be specific. And essentially the way this is operating now, in contrast to the large drug cartels of the past, is now we have small cartels of young Mexican men. They come into the country, set up in towns throughout the U.S., essentially stay in extended stay hotels, buy an inexpensive used car, and then actually deliver heroin to people's door as if they are delivering pizza. And this makes it particularly difficult to control because as soon as one man is arrested, there's essentially another one that's able to come in from Mexico to take that person's place. So that has been difficult to get a handle on over the past 5 to 10 years. And then this is a map of the opioid abuse rates in the U.S. Remember earlier the map was showing the prescription rates across the country, and what you'll notice is that the map of opioid abuse rates very closely mirrors the map of the prescriptions. So very heavily concentrated in the Appalachian region of the country, as well as along the West Coast, southern Nevada, northwestern Arizona. So it looks very similar to the prescription rates that we saw earlier. And so the impact of this has been that there has been a huge surge in drug-related overdose deaths in the U.S. And in fact, in 2016, which is the latest data that are available, more than 64,000 Americans died from drug overdoses. And what you'll see if you look at this chart is that this has expanded and grown tremendously over the past 20 years. So starting in 1999, there were fewer than 20,000 overdose deaths in the U.S., and in a span of about 18 years, that number has more than tripled. So the interesting thing about this is that it has not been driven by the same substance. So what you'll see is on the top line, the green line is overdose deaths involving any opioid. This is the death per 100,000 population. And what you'll see is that those deaths were initially driven by the darker line there, which is the prescription opioids. And that leveled off starting in about 2011 and has remained relatively flat for the past 5 or 6 years. But essentially what started to take off in 2010 and 2011 are overdose deaths related to heroin and other synthetic opioids. And so that has been what has been driving the overdose-related deaths over the past 5 years. And this is just a look at the age-adjusted overdose death rates by state in 2016. And what you'll notice, again, similar to the prescription rates and the opioid abuse rates, the number of overdose deaths are heavily concentrated in the Appalachian region of the U.S., a little less so along the East Coast, but again, in Nevada, Arizona, Utah, New Mexico, along the west, in the west. And so it certainly varies by state and by region of the country in terms of which regions have been most impacted by these overdose deaths. Georgia, fortunately, where I'm from, has been very fortunate in all of this and has not been as heavily impacted as some of the other states. So this is just a look, and you may want to look quickly and see if you see your state in this table. This is a look at how the overdose death rate has changed by state between 2010 and 2015. So if you look at the open circle, that is the rate deaths per 100,000 population in 2010. If you look at the dark colored circle, that's the rate for 2015. And so what you'll see is up at the top, that tends to be the states that have been most heavily impacted, and those are heavily concentrated in the Appalachian region of the country, as well as up into the Northeast, so New Hampshire, Rhode Island, Massachusetts, etc. Again, if you look for your state, you'll see what the change has been for your state. I have an arrow pointing to Georgia, since that's where I'm from, and that the increase has been relatively minimal in Georgia. Very fortunate. Now, the interesting thing about the epidemic is it's really almost two epidemics, separate epidemics. So I showed you earlier that the number or the rate of prescription overdose deaths started to flatten in 2011, and the number of heroin and other synthetic opiate-related deaths started to increase at about the same time. And so a lot of people have argued that essentially as prescription opiates became more difficult to obtain, people started to switch to heroin and other opiates. But the reality looks a little different if you look at the overdose rates in the U.S. By age. And while certainly some of that was probably happening, there were certainly some people who were no longer able to get prescription opiates easily, and so they switched to heroin, which was easier and a lot of times cheaper to obtain. But if you look at these next two slides, what you'll see is that the demographics are a little different. So this is the opioid overdose deaths, prescription opiate overdoses in the U.S. by age, and what you'll see is that the highest number of prescription opiate overdose deaths over that 3-year span was in the 50 to 65-year age range. But if you look at heroin overdose deaths during that same period, those are very heavily concentrated among the younger ages, so the 20 to 35-year age range is where most of the people who are passing away or overdosing on heroin are actually significantly younger than those who are overdosing on prescription opioids. So one of the issues, and you saw this in an earlier slide, is the issue of fentanyl. And fentanyl is a synthetic opioid that is 30 to 40 times stronger than heroin by weight. And what's starting to happen, and we'll see a few slides on this in just a couple of minutes, what's starting to happen is that fentanyl is being added to heroin so that people who are purchasing heroin don't realize the potency of the heroin that they're purchasing. And we've really seen this emerge over the past 4 to 5 years, and you'll see there that fentanyl reports increased by 300% from late 2013 to early 2014. And the interesting thing about this is it's not diverted pharmaceutical fentanyl. It's actually primarily being imported from China, and it's primarily coming into the northeastern U.S., and we'll see that on this map here. So what you'll see, and you'll watch this map over the next couple of slides, watch how the colors change. So this is 2013, and you'll see this is the number of drug products that were tested by law enforcement that were found to include fentanyl. And so it's relatively minor in the U.S. in 2013. It's primarily concentrated in Ohio, Virginia, and Pennsylvania, where they found anywhere from 50 to 250 drug products contained fentanyl. But then watch as we click through these slides. In 2014, more states start to turn darker colors. 2015, still more states start to turn darker colors. So you can start to see the fentanyl spreading from those northeastern states and moving across the country gradually. And so that to me is a really really big concern because it's very difficult to detect fentanyl adulterated heroin, and so many more people are overdosing on heroin because they think they're taking heroin when in fact it contains fentanyl. So this is the percentage of overdose deaths related to fentanyl from 2013 to 2015. And what you'll see is this is the percentages across the bottom. The green is 2013, blue 2014, and brown 2015. And so you can see big spikes in the number of percentage of overdose deaths related to fentanyl, again, primarily concentrated in those northeastern states, Massachusetts, Pennsylvania, Rhode Island, New Hampshire, etc. So big increases in those overdose deaths in those areas, and it seems to be starting to spread across the country. So that's it for the epidemiology slide. So I wanted to spend just a few minutes on a brief history of how we got to where we are, and you'll see several illustrations here. And so essentially what I'm trying to say with this slide is it's a combination of issues. Number one, there was significant marketing by the pharmaceutical industry to try to increase the prescribing of opiates for chronic pain. There was a big push to make pain the fifth vital sign in the mid-1990s, and the Joint Commission really supported this push to more effectively address people's pain. And one of the things that I wanted to mention to you is these next 10 or 12 slides, and I don't have any connection to either one of these authors, but I think these are really great books if you're interested in learning more about the prescription and heroin epidemic in the U.S. The first is just a history of opium that looks at opium all the way back to 3400 BC, and then the other one is Dreamland by Sam Quinones, that really looks specifically at how we have, how the U.S. has gotten into the mess that it's in terms of prescription overdose deaths and heroin-related overdose deaths. So it takes a more recent look at the prescription to opiate and heroin problem. So what has happened, and this has been over the last just a little over 20 years, is a significant increase in opioid use, obviously, initially driven by prescription opioids. Prior to the mid-1980s, prescription opiates were primarily reserved for surgery and for individuals that were recovering from a severe injury, or for individuals who were nearing the end of their life as a comfort medication. In 1980, there was this little letter to the editor that was published by Porter and Jick in the New England Journal of Medicine, and I'll actually show you the letter to the editor on the next slide. But essentially, they concluded that that the development of addiction related to prescription opioids was rare. Russell Portnoy, whose nickname is now the King of Pain, seized on this issue and published a manuscript in the journal Pain in 1986 that looked at what is actually a very small number of patients, 38 patients on opioids followed over 7 years. 24 of those patients reported adequate pain relief. Only 2 of those patients, both of whom had a history of substance abuse, had problems with that long-term maintenance on prescription opioids. As I mentioned earlier, the American Pain Society in the mid-90s really started to push for physicians and hospitals to use pain as the 5th vital sign. And as I mentioned earlier, there was heavy marketing of long-acting opioids by the pharmaceutical industry, and regulatory pressure primarily from the Joint Commission to improve patient satisfaction. And one of the ways to improve patient satisfaction is to address any of their complaints with pain. And so the result was a significant cultural shift in clinician prescribing of opiates beginning in the mid to late 1990s. And I think the next slide illustrates that. No, the next slide is the letter to the editor. So this is it. This is a little 5-sentence letter to the editor from 1980. And if you notice the big arrow there, the last sentence is, we conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. And so that little 5-sentence letter to the editor in 1980 has now been cited over 600 times, with a particular spike following the release of OxyContin. 72% of those publications cited this letter to the editor as evidence that addiction was rare. 80% of those citations failed to note that the little study that they did was on inpatients only in hospital settings. And this has been really cited as a landmark study, despite the fact that it was a 5-sentence letter to the editor. And this is a table showing the citations for the little Porter and Jick article, and what you can see is it was released in 1980. It was relatively unnoticed for the first decade that it was out there, and then it started to get more attention beginning in 1990 and really spiked following the release of OxyContin in the mid-90s. And so essentially this is from an article published in 2017 that went back and looked at the truly was a very limited evidence that prescription opioids can be used safely for chronic pain. And the conclusion of that article was that we found that a 5-sentence letter published in the journal in 1980 was heavily and uncritically cited as evidence that addiction was rare with long-term opioid therapy. So this is really the birthplace of the prescription opioid epidemic as we know it in the U.S. And so this led to really faulty reasoning at the highest level. The Federation of State Medical Boards in the late 90s passed a policy reassuring doctors that there would not be regulatory action for prescribing large numbers of opioids. 2004, they called on the state medical boards to make undertreatment of pain punishable. That particular policy was drafted by a senior Purdue Pharma physician representative. And in fact, the Federation of State Medical Boards received about $2 million from Purdue since 1997. JCO, the Joint Commission, was the same type of issue. They introduced and enforced the pain scale in the mid to late 90s and published a guideline, which happened to have been sponsored by Purdue Pharma, indicating that there is no evidence that addiction is a significant issue when persons are given opioids for pain control. And so the result was a tremendous spike in the number of opioid prescriptions dispensed by U.S. pharmacies. So that this slide's a little blurry, but essentially you should be able to see that in the early 90s, up until the mid-90s, there was anywhere from 75,000 to 80,000 prescriptions dispensed by U.S. pharmacies, and then that number just increased and increased and increased until in 2011 it peaked at about 76 million, peaked at 219 million prescriptions for opioids in 2011, and has since started to taper off a bit, but still it essentially tripled in a span of about 15 years. So 20 years later, I mentioned to you earlier that Portnoy is nicknamed as the king of pain. 20 years later, he has now come back and said, I gave innumerable lectures in the 80s and 90s about addiction that weren't true. Purdue executives have now pled guilty to criminal and civil charges for misrepresenting the risk of addiction to prescription opioids. And then one of Portnoy's quotes was, "We didn't know then what we know now," which is interesting. And again, we'll go back into a little deeper history. One of the things you all have probably heard is the saying, "Those who can't remember the past are condemned to repeat it." That's credited to George Santayana, who was a philosopher. But the fact is, despite what Portnoy may have said, we did know then what we know now, because opiates have a long history of misuse and addiction. So the opium dates back, as I mentioned earlier, to 3400 BC. The Sumerians referred to it as the joy plant. Was widespread use in Europe, throughout the Middle East, North Africa, and was considered as a cure for just about everything for physicians at that time. The Greeks and Arabs also used it quite liberally. The Greeks recognized the characteristics of opium, but also recognized the capacity for it to become habit-forming and for dependence and addiction. Avicenna, who wrote the Canon of Medicine in around 1000 AD, actually died from an overdose to opium. And essentially, wherever Islam conquered, opium was used and distributed prominently in those areas. If we move on to the Renaissance, we find laudanum, which is a tincture of opium, referred to as superior to all other heroic medicines. Laudanum was heavily used by physicians during that time, and the result was addiction, particularly among the upper classes. Opium caused Egyptians to lose their energy and functions and numbed them. That's from Prospero Alpino in 1600. So again, we see that we've known for several hundred years that opium has addictive properties. Initially, there was praise for laudanum. This is from Thomas Sydenham in the 1660s. Here I cannot but break out in praise of the great God, the giver of all good things, who hath granted to the human race as a comfort in their afflictions no medicine of the value of opium, either in regard to the number of diseases it can control. Medicine would be crippled without it. Unfortunately, they also recognized that it had some deleterious effects. Initially, it was being used to treat a number of different ailments in the form of laudanum, including cough, diarrhea. It was given to infants to soothe their mouths while they were teething, or to calm them if they were sick. And in the 1700s and 1800s, we see quotes indicating both praise as well as peril from opium. So what can then cure pain and all its effects better than pleasure? They refer to it as the hand of God, the sacred anchor of life. Here was the secret of happiness. But then other quotes indicate that they realize that there are issues related to opium. Once used, it must be used daily, continued on pain of death. It's a dull, mopish, and heavy disposition. After my death, I earnestly entreat a full and unqualified narrative of my wretchedness. So a combination of joy and peril throughout the 1700s and 1800s. Those became more evident in the late 1800s and 1860. 1/3 of all poisonings were due to opium. 1806, opium was manufactured into morphine. The hypodermic syringe in 1853 really escalated the recreational use of morphine, and disease emerged, referred to either as morphinism or the soldier's disease. Essentially, it was addiction. That was the term that it was given at the time. Heroin was first discovered in 1874 by C.R. Adler Wright as he was looking for the Holy Grail for pain relief. It was actually manufactured by Bayer and marketed by Bayer at the time as a non-addictive cough suppressant, and ironically as a cure for morphine addiction. But essentially history was repeating itself. So again, a new product, but the same issue that has always existed with opium is that it is heavily addictive. And when you get it into these concentrated forms, such as morphine and heroin, it is even more addictive. So it became a global scourge in the 19th and 20th centuries through the East India Trading Company, who essentially traded opium with China in exchange for tea and silk and other goods that they could resell in Europe. It's heavily used throughout Vietnam and the Cold War. An underground economy emerged known as narcoeconomics, and it's been heavily linked to human trafficking in the sense that men become addicted to heroin and will use their partners, spouses, girlfriends, etc., in the sex trade in order to obtain money to purchase more heroin for both themselves and their partner. And so the comment that we didn't know what we know now is really patently false. History repeated itself again in the late 20th century. And what you see to the right there is the consensus statement from the American Academy of Pain Medicine and the American Pain Society on using opioids for treatment of chronic pain. And I've highlighted just this paragraph here. Pain is often managed inadequately despite the ready availability of safe and effective treatments, meaning prescription opioids. So that's sort of the background of how we've gotten into the mess that we've gotten into. More recently, people now are paying more attention to the real evidence of long-term opioid treatment. Over the past 3 years, there have been 3 systematic reviews that looked at long-term opioid treatment for chronic pain. The AHRQ systematic review reported that there had really been no study of opioid versus a placebo effect, no study of an opioid versus a no opioid or opioid versus non-opioid prescription evaluated with a greater than 1 year outcome. Most of the RCTs that were in the systematic review had outcomes of less than 6 weeks. Almost all of them had outcomes of less than 16 weeks. So no one knew what the long-term outcome of long-term opioid treatment was going to be. And in fact, this systematic review reported that there is more evidence available on the harms of long-term opioid treatment, including an increased risk of overdose, gradually increasing tolerance with higher doses, increasing the risk of overdose, the risk of abuse and dependence, fractures, meaning falls related to taking prescription opioids, etc. And then this slide just shows, this was from another study just published within the last year, shows the probability of continuing to take prescription opiates after just a single prescription for opioids. And so essentially it's showing if you get how many days supply, and based on the number of days supply of your first prescription, what are the odds that you'll still be taking prescription opiates 1 year later and 3 years later. So if you look, for example, if an individual gets an initial prescription for opioids, a 30-day prescription, the odds that they will still be taking a prescription opiate 1 year later is about 35 to 40%. And 3 years later, 20 to 25% will still be taking prescription opiates 3 years later, just based on getting a 30-day initial prescription. So addressing the epidemic from a public health approach. It is recognized in the U.S., and we are making some efforts to address the prescription opiate crisis and heroin crisis. These are headlines from the last year. So CVS announced that it would limit opioid drug prescriptions as part of the national epidemic. So if you come into CVS with a prescription for 30 days, I think they're only filling a 7-day prescription. President Trump in late 2017 declared the opioid crisis a public health emergency. There was a commission on the opioid epidemic. I'll show you the headlines of that report in a slide in a few minutes. Lots of doctors are starting to cut back on opioids, so we're starting to see headlines in the news that suggest that we're taking steps in the right direction. In terms of approaching it from a public health perspective, one area that we would need to focus on is primary prevention, and these are just a few of the prevention resources that are available primarily for schools, for younger people. So there is a program called Not Prescribed, which is on prescription drug abuse prevention that can be implemented in the class as a classroom-based lesson. There's one called Operation Prevention that again is focused on students and teachers and parents. Another one called Prevention Plus Wellness that's similar in the sense that it's focused on younger youth and adolescents. The other primary prevention approach is through physician education. So there's something funded by the National Institute on Drug Abuse called the PCSSO, which is the Providers Clinical Support System for Opioid Therapies, and its role is to train and mentor physicians on the safe and effective use of opioid medications. SAMHSA also funds a number of training grants to teach people to do screening and brief intervention and referral to treatment. And then the Hilton Foundation also has a number of grants to better address substance use and abuse in adolescents. Prescription drug monitoring programs, those are now in existence in every state, and you'll see the headline down here at the bottom. This is from July of last year. Missouri became the last state to create a prescription drug monitoring program, and essentially the purpose of those is to prevent doctor shopping. So physicians are supposed to check the PDMPs prior to prescribing an opiate to make sure that the individual they're prescribing to does not have an outstanding prescription with another physician. The issue there is that those tend to not communicate very effectively across state lines. So if you're on a border city the way I am, I guess it's right on the border of Georgia and South Carolina. Theoretically, a patient could get a prescription here in Georgia and then drive right across the state lines, see a physician over there, and the PDMP between the two states would not communicate with each other. You can't see that very well. What this chart shows is that the PDMPs have been relatively effective. This is a question about to individuals about where they obtained their most recent opioid, and only about 1.4% report that they have a prescription from more than one physician. The majority of the access to opioids actually continues to come through family members or friends, which is this brown area, light brown area to the left. So medication-assisted treatment in opioid use disorders. There are 3 FDA-approved medications for opioid use disorder: methadone, buprenorphine, naltrexone, and then there's naloxone is used to reverse overdoses. And just recently, this was December of 2017, so in the last 6 or 7 months, the FDA approved an injectable buprenorphine treatment for opioid use disorder, and it's called Sublocade, which I have listed here under buprenorphine. So methadone is an opioid agonist, has a long half-life. It doesn't give you the same sort of high that heroin or oxycodone would. It's been shown through numerous randomized controlled trials to reduce drug use, and typically an effective dose is about 60 to 120 milligrams a day. A methadone program, you cannot prescribe methadone maintenance through primary care. There has to be specifically licensed programs. Those require observed dosing, regular urine drug screens, monitoring for alcohol use, and for legal and social problems. In terms of outcomes, as I mentioned, numerous randomized controlled trials that found that it reduces illicit drug use, decreases mortality, reduces the risk of HIV infection, criminal activity, and so on. So it's really quite effective. The issue, though, is that there's limited availability. It's only available in licensed clinics. Those licensed clinics tend to be in urban areas, and the prescription and heroin epidemic, as you saw early on, today is really heavily concentrated in rural Appalachia and other places where methadone clinics would not be located. And there is a stigma that continues to be associated with going to methadone programs, and they're heavily regulated, requiring daily attendance. So it can really feel quite oppressive and sort of like you're in shackles because you have to report each day to get your dose. Buprenorphine is one of the other medications that's available. It can be taken sublingually through Suboxone, which was approved in 2002. And then more recent formulations, as I mentioned, is an implant as well as the once-monthly injectable. There are some guidelines governing buprenorphine. So a physician, in order to qualify, has to complete 8 hours of special training. Initially, you can have no more than 30 patients, but it can increase it to 100 patients per practitioner after 1 year. And you have to register with the DEA, and the DEA can actually make visits to your clinic and inspect your offices to make sure that you're using it appropriately. This was expanded a bit through the Comprehensive Addiction and Recovery Act of 2016. So it had the goal of expanding prevention and education, expanding access to naloxone, strengthening PDMPs, and expanding the use of medication-assisted treatment. And so the result was that physicians can now have up to 275 patients on buprenorphine, and it also authorized nurse practitioners and physician assistants to prescribe buprenorphine, although interestingly they have to complete 24 hours of education as opposed to just 8 hours of education that is required of the physicians. So this is the number of certified physicians in the U.S. Right now there are 37,000 physicians who have been certified and are allowed to prescribe buprenorphine. What you can see is that most of them are still at the 30-patient limit, so they really haven't advanced beyond the 30-patient limit. Only a small percentage of them have been certified for the 275-patient limit. And so even though buprenorphine can be administered in primary care settings, the majority of the physicians that are waivered are not prescribing at their patient limit, and it's been difficult to get physicians, because of the stigma associated with drug use, it's been difficult to get physicians in primary care to agree to undergo the training and to start taking on buprenorphine patients. And a recent study looked at reasons that physicians do not prescribe, and they cite a lack of training, a lack of institutional support, a lack of mental health and psychosocial support within their areas, low reimbursement, lack of staff training, lack of time, stigma, etc. So there are lots of barriers to being able to adequately provide medication-assisted treatment in primary care settings. Extended release naltrexone is another option. The trade name for that is Vivitrol, and essentially it's a once-monthly injection that was approved by the FDA in 2010. Key points about injectable naltrexone is it's administered monthly. It can be administered by any individual that's licensed to prescribe medicine. So unlike buprenorphine, you don't have to go through additional training. It's an intramuscular injection. Some of the downsides to it are that there's the potential for adverse reactions near the injection site. You have to be completely detoxed from opioids before you can initiate Vivitrol. And then the cost is really prohibitive in a lot of ways. It costs about $1,300 per month for a Vivitrol injection. As I mentioned, naloxone is an overdose reversal medication. It's an opioid antagonist that displaces the opioid agonist in case of an overdose. It's now distributed to patients and family members and significant others, as well as emergency and rescue personnel. The CDC guidelines encourage providers to consider naloxone prescriptions for patients with higher opioid doses or a history of overdose or a history of a substance use disorder. A lot of states now, including Georgia, have passed a law that will allow pharmacies to distribute naloxone without a prescription. So essentially, the director of the State Department of Public Health becomes the physician of record for naloxone, and so family members or active users that are concerned about an overdose can go in and get a naloxone in the form of a nasal spray from pharmacies without having to have an official prescription. So barriers to treatment and using medication-assisted treatment is cost, particularly for injectable naltrexone. Accessibility, as I mentioned, methadone clinics tend to be concentrated in urban areas, and much of the epidemic over the last 10 years has been in rural areas. The diversion and abuse potential of buprenorphine, the myths of medication-assisted treatment as a substitute addiction, and then for methadone clinics, just the stigma and the time involved in going to get your daily dose. And then insurance coverage is not particularly strong for medication-assisted treatment. Some states limit the length of time that the medication can be used, and in most states, Medicaid doesn't cover all three of the medications that I mentioned. So one example that has not been tried in the U.S. that is promising in Canada is Vancouver's Insight program. It's North America's first legalized injection site, something that the U.S. may want to consider to cut down on the number of overdose deaths. The drugs have to be personally acquired, but the injection site provides clean syringes, needles, safe disposal, as well as safe sex education, nursing services for individuals who have health care concerns, and then a direct link to substance use disorder treatment if the individual is interested in seeking treatment. So recent U.S. efforts, I mentioned the President's Commission on Combating the Drug Addiction and the Opioid Crisis that was just released in November of 2017. And then here are some very recent requests for applications from SAMHSA and from HRSA related to the opioid epidemic. There are state opioid response grants which have been given to each of the states to try to increase the use of medication-assisted treatment and the availability of treatment and to expand the use of naloxone, et cetera. And then HRSA here is focusing on rural communities, and this initial round of HRSA grants are planning grants, so essentially identifying the gaps in those communities and then creating a strategic plan to address those gaps. But more is needed. What we really need is a comprehensive and coordinated strategy around prevention as well as treatment. Some consumer-directed media campaigns about the risk of opioids, public education about naloxone, increasing prescriber use of the PDMP, because in most cases you have to get out of the electronic health record to access the PDMP. Physicians have been hesitant to use it and don't use it as frequently as they should. Insurance that supports safer opioid prescribing and appropriate treatment. In terms of treatment, we need an increased use of medication-assisted treatment, expanding treatment access and capacity, incentivizing providers to enhance the quality of screening and brief intervention to identify people who are at risk before they progress to dependence or before they overdose. And then overdose prevention, expanding naloxone availability. A standing order, as I mentioned earlier, Georgia has a standing order for getting naloxone into the hands of those who need it. Not all states currently have a standing order. Explore the potential use of engagement sites, establish coordinated and rapid response to outbreaks, etc. And so the other piece would be a dashboard where we have all of this information coming in so that we could respond as needed, particularly to high-risk areas. So unfortunately, while that's the ideal, that is not the reality. This is the world that we live in. This is a sign that was posted outside of a Kenton County, Kentucky courtroom. Suboxone users, if you want probation or diversion and you're on Suboxone, you must be weaned off by the time of your sentencing date. We won't really focus on the misspellings there, but essentially they misspelled a number of words, but it really just illustrates how there's still stigma attached to medication-assisted treatment, and it's viewed as a replacement instead of a solution. This is a quote from Dr. Tom Price, that was our former Secretary of Health and Human Services, who really touted faith-based programs and was not supportive of medication-assisted treatment. He said, if we're substituting one opioid for another, we're not moving the dial much. Folks need to be cured so they can be productive members of society and realize their dreams. And then Jeff Sessions in May of last year called for harsher sentencing penalties for a simple possession of drugs, so definitely moving in the wrong direction. And so that's where we are, and that's my presentation. So I'll be happy to answer any questions that you might have or hear any feedback you might have. But thanks for listening. So I'm going to move it back over to Amy for the next couple of minutes.
Great. Thank you so much, Aaron. That was an awesome presentation. We do have one question in the chat box, if you don't mind answering it for us.
Yeah, I see. You mentioned that Medicare doesn't cover the drugs needed to help an addicted person. Do they prevent distribution of opioids initially? I'm not sure I understand that question. Does Medicare prevent the distribution of opioids initially? Amy, can you help with that?
Yeah, Angela, do you want to clarify your question? I think what she's asking, are there any Measures, okay, so Angela says, does Medicare prevent doctors from sharing these? I guess distributing opioids.
From no, not that I'm aware of. So Medicare would cover the prescription opioids, oxycodone, hydrocodone, et cetera. Yeah, that is not an issue. And Medicare will cover some, well, it depends, it's actually Medicaid more than Medicare. So Medicaid varies by state. So Medicaid in some states will cover the 3 approved medication-assisted therapies, but it does not in all states. So for example, it may cover methadone for a limited length of time. They may cover buprenorphine, but would probably not cover the injectable buprenorphine. So yeah, but Medicare definitely covers hydrocodone and oxycodone and does not necessarily place limits on physicians in terms of how they can prescribe those.
Okay, great. So there's one more question in the box there.
Okay,
can you comment?
I have it. Can you comment on the quality of data across the country and how that may affect the resourcing for areas that are possibly in greater need than demonstrated by the data at present? That's a good question, and the quality of the data certainly varies from state to state, and a lot of states were way behind in terms of getting rapid, up-to-date data. And so what you may have noticed in my presentation is even at a national level, the most recently available data is from 2016, and we're now 6 months into 2018. So getting rapid, real-time, up-to-date data on, say, for example, outbreaks in opioid overdoses in a certain county or a certain neighborhood would be next to impossible. But there are states that are trying to make headway in that, and Georgia is actually one of them. I don't know exactly what other states are doing, but I'm part of a strategic planning committee that's being run by the State Department of Public Health here in Georgia, and so they're bringing together stakeholders from all over the state and at all levels to try to do a better job of getting real-time data and getting help where help is most needed. Okay.
All right, so we have one more question.
Sure. It would seem that more programs to combat opioids that have been proven to work in other countries, for example, UK and Canada, are not readily adopted in the U.S. Is there any particular reason for that? Well, I can tell you the reason that the safe injection site, as we've seen in Vancouver, has not been adopted in the U.S., and that is because the political climate of the U.S. would not allow for that. It would be very difficult to implement that type of program in this country, unfortunately, because people just aren't open-minded to that type of approach. Our country continues to be, and has probably shifted more this way in the past year and a half, continues to be very focused on criminal punishment for drug users as opposed to a harm reduction approach for drug users. And so an injection site like that would not be welcome in the U.S., unfortunately. So there's still a lot of work to do to address the stigma that we see here. That's exactly right. That's also why we don't see a widespread use of needle exchange programs.
Okay, well, thank you everyone so much for the great questions, and thank you, Erin, for the presentation. And as a reminder, the presentation today was recorded and we posted on the NNLM YouTube page as soon as we can. I also encourage you to subscribe to our YouTube channel so that you'll be notified as soon as new recordings are made available. I'm going to go ahead and share the link to our YouTube channel in the chat box. Also, Aaron has agreed to let us share his presentation slides. So once the recording is available on YouTube, I'm going to email everyone who pre-registered for the webinar a link to the recording, and I'll also send a PDF of the slides in the next couple of weeks. Our next webinar that the SEA region is hosting is taking place on Thursday, August 23rd at 2 p.m. Eastern. The webinar is an NNLM Journal Club session on graphic medicine. Details for registering for the webinar are available on nnlm.gov. To evaluate today's webinar and receive your MLA CE credit, please visit the link, the following link. I'm going to post that in the chat box as well. Once you've completed the evaluation, you'll receive instructions on how to claim MLA CE credit through the MedLib Ed website. And thanks again, everyone, for attending today's webinar. And thank you so much, Erin, for taking the time to present the webinar for us. It was wonderful. So you all have a great afternoon. Thanks again.
Thanks, everybody. I enjoyed it.
Thank you so much, Erin.
Thanks. Bye.
Bye.